So the last time we had an epidemic of this proportion was the AIDS epidemic, in terms of having one illness that caused a direct impact on mortality. And just like with the opioid epidemic, there was this just linear increase in overdose deaths until 1997. And in 1997, antiretrovirals were discovered, and deaths related to HIV and AIDS started to go down, and the number of people living and managing the illness went up. We have the only thing we know that reduces mortality risk in persons with opioid use disorder are buprenorphine and methadone. That's it. And yet still, in 2014, the amount of money that came from the federal government for substance use disorders in Missouri was about $40 million. Through special grants over the last few years, STR and SOR, in 2018 it was $75 million. Still today in Missouri, if a person calls to try to get buprenorphine or methadone on any given day, almost anywhere in the publicly funded system, there's a wait list. So one of the things we have not done is integrated medical treatment of opioid use disorder within the normal mainstream medical system. Part of that is because of the way the money flows. The money is generally flowed into non-medical settings. The Department of Mental Health was innovative in allowing me to go out as a consultant and try to expand buprenorphine and buprenorphine treatment, because methadone has to be done in OTPs, in primary care settings across the state. And where that has happened, the rate of treatment of people in the community is much higher. If a federally qualified health center or a rural health clinic gets into the game of treating people with opioid use disorder, they tend to make it much more available than the traditional substance use disorder programs. So to give you a couple examples, down in Springfield, Missouri, Jordan Valley is a federally qualified health center. They went out to get their own money from the Missouri Foundation for Health because they're not a funding recipient. And now they have 1,000 active patients, 5 to 10 times more than the local substance use disorder treatment program. In Northwest, up near St. Joe, Northwest, and Jordan Valley are the only places in the entire state that I know of where they still accept walk-ins with opioid use disorder. So if you have a problem, you can walk right in and get treatment. I do not know of a single traditional substance use disorder program that has walk-ins at this point. They did early when the money first came out, but now that the money's being divided and not as available, they can't. I don't see how we get the effect that we got with the AIDS epidemic until when someone shows up at their doctor, they get treated for opioid use disorder. The medication that we use to treat opioid use disorder is a Schedule III medication. It's not complicated to prescribe. There's 4 normal doses. It has a ceiling effect on respiratory depression, and yet still, even with all the funding we've gotten in the past 3 or 4 years, we've not been able to make it available in primary care settings in the mainstream healthcare system. I do not think the solution comes from funneling money into the same systems of care that we've used until now.